All right, it is 1 o'clock, so we can begin. Hello and welcome to the first ever BroncoFit virtual concussion seminar. Thank you all for joining us. I am Soraya Harvey. I am a BroncoFit peer health educator for the Campus Wellness Program. Today we have Dr. Lyons, the university's sports medicine physician, and Christy Pardue, the director of the St. Luke's Concussion Clinic. Dr. Lyons, if you want to briefly introduce yourself right now, that would be great.
Yeah, thanks, Soraya. Yeah, my name's Trek Lyons. I work both with Boise State over at the Student Health Center and then at St. Luke's in the orthopedic department.
Awesome, great to have you here. Christy, if you want to briefly introduce yourself as well.
Sure, I'm Christy Pardue and I manage our St. Luke's Sports Medicine Concussion Clinic and appreciate the invite to speak today.
Thank you for being here. Today, this is our agenda we're going over. Christy will be speaking first about a few topics, and then Dr. Lyons will be, and then at the end, there will be some time for questions. In the meantime, if you have any questions that come up throughout, feel free to enter those in the chat, and then we can circle back and hit those at the end. All right, Christy, you are free to take it away.
Okay, I'll try. All right. Well, again, thank you for inviting us to come and speak today, or to speak today. My name again is Christy Pardue. I'm actually a speech language pathologist, and I'll talk a little bit about that in a second. But I manage our sports medicine concussion clinic here at St. Luke's. We've been in existence for about 8 years. And we're going to talk about today just the importance of education with concussion, signs and symptoms, then also the importance of self-reporting, whether that's an athlete, student, what have you, and then how to check on each other, whether teammate, friend, child, etc. Today, I'm speaking. It was supposed to be Corey Bell, who is our community relations coordinator, but he is in the hospital right now with his wife, and they're in the process of trying to bring their little girl into the world. So a little bit about myself before I go on to Corey. Like I mentioned before, I'm a speech language pathologist, and my career started in the schools in rural Idaho, then took me to Missoula, Montana, where I worked in from Head Start to 12th grade on the Flathead Indian Reservation, a hospital in Missoula, Montana, then community medical center, where I specifically focused on treatment of individuals with more moderate to severe traumatic brain injury in pediatrics and adults. And then back to Idaho. I'm from here originally, but back to Idaho, worked at Elks Rehab for 10 years on their inpatient and outpatient brain injury team, and then had the good fortune of getting to help develop and create this concussion clinic that we have here at St. Luke's for the last since 2012. So that's a little bit about me and kind of where my experience comes from. My majority of my career has really been focused on treating patients with traumatic brain injury, from more moderate to severe to more mild, like concussion. I thought we'd just kind of level set right out of the gate, and most of you on this Zoom meeting probably know what a concussion is, but just in case, we're just going to talk about what the definition is, because even in the medical community, with as much as concussions in the media anymore, there's still confusion on what exactly is the definition of concussion. And so it's just important to know that a concussion is a type of traumatic brain injury, and it can be caused by a bump, blow, or jolt to the head. So it doesn't always have to have a direct impact. A lot of people think, well, they didn't hit their head, they don't have a concussion, but that's not necessarily true. You can see that in sports-related injuries. You can see it in motor vehicle accidents where there may not be a direct hit to the head, but there's a blow to the body that can cause our brain, which is a gelatinous material, to move back and forth. I think the other thing that's important to know is a concussion, the definition that we utilize of concussion, or the most widely accepted, is there's no abnormal imaging. So there's no bleed or skull fracture. The imaging is clear, although most of our patients don't need advanced imaging because there isn't that. They're only going to do that if they are worried about more significant injury. I think one of the other things I want to call out is the severity of a concussion can be very different based on each individual, depending on the accident, the duration of symptoms, etc. It's really highly variable. So we always say, if you've seen one concussion, you've seen one concussion. You really can't compare one person to another. Healthcare providers describe it as a mild traumatic brain injury because concussions aren't typically life-threatening, but the effects of them can be severe and long-lasting, and especially when they're not managed appropriately, which we're going to talk a little bit about today. When we look at the signs and symptoms of concussion, we usually break them into 4 categories, which is physical, cognitive, emotional, and sleep. And if you're trying to remember, okay, what are the names of those 4 categories? You can always think about The Rock and his pecs. So that's the acronym that we like to use when we go out and educate in the community, or we're educating other medical providers or even students. We have a whole school curriculum that we help facilitate within the school districts. The one important thing to call out on these signs and symptoms is that a person does not have to lose consciousness to sustain a concussion. That still today is really one of the myths. And it's one of the misunderstandings about concussion. We'll even have medical providers say, well, they didn't lose consciousness, they must not have sustained a concussion. 99.9% of the patients that we see, and we see a lot, don't ever lose consciousness. So I think it's really understanding what is the current understanding of concussion as you're moving through these various educations. But any of these signs and symptoms certainly can cause somebody to have difficulty in their job or their academic setting. So it's important to recognize these out of the gate. So at St. Luke's, we talk about what's our why, like why do we come to work every day? Why do we have certain programs in existence? What's your why? And so our why in starting this concussion clinic, one of the things is that according to the Center for Disease Control, they estimate 1.6 to 3.8 million sports-related and recreation related concussions in the US. So only 1 in 6 though are diagnosed. So just those numbers alone can explain why this is such an important topic. And it doesn't just occur in sports, even though that's really what oftentimes people are talking about. It can recur in any walk of life. And so the other component of this that's really important is when we talk about only 1 in 6 are diagnosed, that means there's a lot of people that are, that diagnosis is missed, whether it's on purpose, maybe the person isn't being truthful about their symptoms, or they just don't even understand that's what happened. So that's kind of our why behind why we exist here at St. Luke's, because our goal is to either prevent this when we can, or make sure that there's appropriate management in place. And we do that by having kind of 3 pillars. That one is clinical coordination and medical management. The other one is education and outreach. And then the third is research. And so over the last 3 years, we've really built out these 3 pillars in order to best serve our community. Corey Bell, who's supposed to be speaking today, but is in the hospital with his wife, he's our current community relations coordinator. And he's one of our staff that's his full-time job is going out into the community and working with local schools, youth sport organizations to build and implement concussion protocol. In every state in the US, we have youth sport concussion legislation, which mandates protocols be in place to protect those student athletes. It also mandates that they receive education, the coaches do, the officials, parents, and athletes. So we have one full-time person that's just dedicated to that, and that happens to be Corey Bell right now. They also work various community health events or do presentations like we're doing today to promote concussion education and awareness. I think it's interesting to note that over the years since we've been in existence, we've had 3 of our 4 community relations coordinators have been Boise State athletes, particularly football. And I think the helpful part of that is they bring an athlete's perspective. Doesn't mean we couldn't have another community relations coordinator from another sport. It just has happened to be football, 3 football players, Matt Kaiserman, Jake Hardy, and now Corey Bell, who have all been phenomenal unique individuals that have just added a ton of wealth of knowledge to our team. But I think having athletes like Corey, like Jake, like Matt Kaiserman, be the ones that are out doing our education in the community adds a perspective that oftentimes, like myself and the physicians that work for our concussion clinic don't have. We have more the clinical perspective, but he has the athlete's perspective and he can kind of see it from every angle. And I think that's important when he's the one going out and educating athletes and various people in our community, because he can speak to them in a totally different way and from a different perspective than anybody with a clinical background. And so we're just really thankful to have him, as well as our partnership with BSU, whether it's from research projects to working with Mark Paul to make sure that, you know, we're all on the same page in terms of concussion management, et cetera. So one of the components that we wanted to talk about today is when you look at education that we provide in the community, like I mentioned earlier, there is concussion legislation across all states in the US that mandates that schools, youth sport organizations have a concussion protocol. And for after high school, and you look at the college level, it's the NCAA, et cetera, all those overarching entities mandate that there's concussion protocol in place. But the concussion protocol and what that typically looks like is making sure that there's a plan for removal from play if somebody's suspected of having a concussion, that everybody's on the same page of what are the next steps, that they have to see a healthcare provider, that there's a process in place. If we only have concussion protocol alone and we don't do concussion education alongside it, and I'll go into that in a minute, if we only have that protocol in place, which oftentimes from an athlete's perspective or from a student's perspective, they only know about the protocol, which is there's a plan to take me out of the game or take me out of whatever activity I'm doing if I sustain an injury. And that's about as far as they know. And so from an athlete, they just know there's going to be a process for keeping them from playing, but they don't understand the importance of why that protocol is in place or why that legislation is in place unless we do education. Oftentimes we would see this lead to them potentially hiding the injury. We've all heard about that. From a coaching perspective, they know they've just lost an athlete to concussion protocol. So once that athlete's suspected of having a concussion, they're removed from the game or practice or whatever. And from a coach's perspective, they just see that as a loss potentially. And they may be frustrated with the athlete if they don't understand what concussion is. If they don't understand, you can't see that injury, it's going to be a symptom-based diagnosis, et cetera. Also, if they have a lack of recovery time, so the coach may not understand the sooner that we get the patient or athlete what they need, the sooner they're going to get back to the game. From a healthcare provider's perspective, they may not understand, well, why isn't the athlete coming to see me? Don't they understand my goal is to get them back to the field as soon as possible? So taking each of these perspectives, and we only talk about a concussion protocol alone and we don't talk about education, we're missing a huge gap or a huge opportunity. So if we, on the flip side though, if we only do education, we don't have a protocol, then we have a situation where we've just paranoid an athlete. They're maybe not likely, maybe they're more likely to report, but they're not sure to do what to do if they do report. The coach may only know, well, I need to pull the athlete if they're suspected of having concussion, but now I don't know what to do with them if I have pulled them. Healthcare providers, same thing. Why aren't they coming to see me? I just want to help. They don't know the goal is to get them back as soon as possible. So what we've realized over the years when we work with organizations and they understand from a legislative point of view that they need a concussion management protocol in place, they'll often call us and say, oh, can you help us develop this, which is what we do. But until we're able to mesh that protocol as well as the mandatory education that's supposed to occur at the same time, they don't fully appreciate or understand what both entities can and be helpful for their organization. More and more there's research coming out that talks about removal from play after concussion and recovery time. This is one of the articles that we use sometimes to speak to when they take a handful of athletes, and out of those athletes, 35 athletes were removed immediately from play, which resulted in a 22-day recovery period. And then the 34 athletes continue to play resulted in a 44-day recovery period of time. So what it shows is the sooner that you can identify, if you suspect somebody had a concussion, the sooner they are removed and started on that management or that protocol, then they're going to actually get back to sport sooner. And we see this all the time in our patient population. However, let's say the athlete doesn't communicate that they maybe are having signs and symptoms, or the coach doesn't pull them, or their teammate doesn't speak up when they notice something odd, or them just not behaving like themselves, then that typically results in a longer recovery time, even though that's not what their intention is. So some of the risks that we see in terms of everybody not being on the same page, or maybe there being a discrepancy between a protocol and education, or somebody getting appropriately managed for their concussion. This doesn't happen all the time, but are two risks that we always kind of have in the back of our minds. The first one is the second impact syndrome, and that's, we have seen this happen in Idaho a couple times. It's not really very frequent, and often it's actually really rare, but it can happen, and it was the catapult for legislation across the United States, and that's second impact syndrome. And so basically what that is an athlete maybe they're playing basketball and they sustain a concussion, aren't removed from play before that injury is actually resolved. And so maybe they continue to play, or the next day they have another game or a practice and they sustain another concussion, and then you have a more significant and lifelong impacting injury. And sometimes that can result in death. Again, we have had this happen in Idaho. It's rare, but that is one of the driving forces for all of this education around concussion. The other component that we think about when we're looking at risk factors is persistent post-concussion symptoms. And so really that's defined as symptoms lasting longer than you'd expect. And there's variability in what resource you look at. Some say anytime the symptoms last more than 4 weeks. Others say it's more than 3 months, but typically, in adults, it's going to be 2 to 3 weeks, and 4 weeks in kids. Again, there's a little bit of a moving target on what everybody defines as persistent post-concussion symptoms. But what the take-home message is again, if everybody's on the same page in terms of awareness and education, we can reduce these risks. And that's why we're here today, really. When we look at the ideal situation, so what's the ideal situation when you have a protocol and education, or the importance of education? That really occurs when an athlete knows what the signs and symptoms of concussion are. They understand what the risks are playing through a concussion, like what we just mentioned, the persistent post-concussion symptoms, or second impact syndrome. They understand what happens when they enter the concussion protocol. So rather than being seen as something negative that's going to keep them out of the game, think entering that protocol, knowing that they're going to be removed from play, they're going to get care with a qualified medical provider who's going to make sure they get back to class successfully and then get back to sport safely. They have somebody walking them through that process versus just seeing it as, I'm going to get removed from play. They also know that the healthcare provider actually wants to get them back quickly. If we have education alongside a protocol happening simultaneously, we also have a situation where the coach understands the signs and symptoms and can remove that athlete. They're aware. They understand the risks of letting an athlete play through a concussion. They know what to expect as the athlete enters this protocol. And they also know that the healthcare provider or the physician or the athletic trainer wants to get that athlete back as soon as possible as well. And building trust with the healthcare provider. I think if the athlete and the coach know everybody's on the same page, that can go a long way. The actual healthcare provider, again, whether that's a physician or an athletic trainer, are best able to serve the patients and athletes. Now, today we're talking a lot about athletes, but this really goes for anybody that sustained a concussion. So everybody understanding what are the signs and symptoms, what are current concussion management guidelines, so that whether a person's trying to get back to sport, back to school, back to work, it's very similar. When we have a university setting or college setting or what have you, it's really crucial. I think the other one I would add to Corey's list here is faculty members, and they play a really vital role in creating an environment for students who have sustained a concussion to get back into that academic area. When we look at resources at Boise State, we work a lot with the Educational Access Center. When we have patients, maybe have seen some of our physicians who have sustained a concussion, maybe they've been in a car accident or they have, fallen on the ice, what have you. One of the first things we tell them is to reach out to the Educational Access Center so that they can help communicate with the faculty that those students have. It's really easy to focus on coaches and athletes and, healthcare providers. But one of the big groups that we also try to educate for K through 12 are teachers, and then at a university or college level, the faculty. Because if they don't know the signs and symptoms, or they don't understand concussion, they may be the one piece in this puzzle that really ultimately becomes the barrier or the hiccup. But if they understand about concussion, they understand like supporting that student as they come back is actually going to get them back to class faster than if they don't, or they understand, they look fine, when in reality, you can't see this injury. What are the signs and symptoms to watch for? How can I modify their work? Those go a long way to really working as a team. And so we do a lot of education for different teachers in the community or faculty in the community around concussion, because I think that that's one piece that oftentimes gets overlooked. Our legislation in Idaho, actually, we have a return to learn component. We're one of the few in the US that incorporates that, because we know that it's really crucial for students to get back to the classroom before they go back to sport. Again, any one of these signs and symptoms can really lead to a challenge when you look at someone's academic life, right? So if somebody's got headaches, or maybe they're not sleeping well, or they're dizzy or having blurred vision, all of that's going to impact anything they do academically. So again, it's just really important, that team approach, that we are all on the same page. One of the things we also talk about is self-reporting. And so I think over time, there'll be a cultural change in how people look at concussion. But I think creating an environment that athletes can feel comfortable reporting, or students can feel comfortable going up to a faculty member and saying, I was in a motor vehicle accident this weekend. I don't feel well. I'm in the process of going and seeing a physician, or maybe they need guidance on what they should do. That's crucial. Whether it's an athlete or a student, knowing that they have that support. Also, when you're talking about athletes, they don't have that pressure to return to play too soon. And one of the other things that Corey talks about is, from a coaching perspective, that not playing favorites in terms of, if you can't do this, maybe we're going to put this athlete into play in that particular spot on the team. And then it frustrates the one that's injured that much more because they've lost that role. Also trying to include that injured athlete in maybe there are activities that they can do, like maybe they can go to some of the team meetings, that type of thing. Maybe they can't play quite yet, but they can go to some of the meetings and still feel like they're part of a team. So from an athlete perspective, changing the culture around concussion, making sure that they're supporting each other, asking them how they're doing. Maybe somebody's had a concussion, one of the teammates had a concussion. How can they be included? Whether it's game plan conversations, normal conversations about friends, classes, etc. Doing those things that you can and supporting them. I think one of the things that we see, even with all of the patients that we serve, any grade level, whether it's K through 12 or collegiate, anytime we have an athlete, one of the risks that we first think about is social isolation. And so the more we can be mindful of that, that's also going to help with the recovery period time. So if an athlete can't go play or participate in a sport, well, there goes their social network oftentimes, right? And so how do we keep moving forward without increase in isolation, as well as other concerning factors that can appear? One of the other things we as healthcare professionals need to keep in mind is when we change this culture, how do we encourage self-reporting? That's also making sure that the athletes and the patients know that our goal is to get them back to the game. It's also for them to not just feel like they're not in control. They have a say in their medical care in terms of helping make decisions, or they're really in charge of when we recommend rest breaks. The more they can follow those, the faster they're going to get better. We as medical providers need to make sure that we get creative when we are working on their concussion treatment plans and talk about activities that they enjoy, that are personal to them, as we move through increasing the activities that they can do. Again, recognizing that it's a team effort, that everybody's on the same page as we work through the process, we're going to have a better outcome. The other key, and we talk about this a lot when we go out and do education with teachers and faculty, is the student athlete or this person with the concussion may not be the best one to recognize that they're having their symptoms, right? And so because of the concussion, that might be a barrier in their level of awareness. And it's really on friends, coaches, parents, healthcare professionals, et cetera, to help them navigate through that process. One of the things that we provide to coaches in the area, and this is more along the lines of high school and youth sport athletes, or let's say even bogus basin ski patrol, when they're looking at, trying to not necessarily diagnose, but what are the things that they need to watch for in terms of suspecting a concussion? There's a lot of tools out there like this one, the concussion recognition tool, that goes through signs and symptoms, but really oftentimes it comes down to just common sense. So knowing that athlete or knowing that student, knowing your child, whoever it is, and you oftentimes know that they just maybe seem off. And sometimes we'll have parents call and just say, gosh, I should have known, I just had a feeling, I was seeing all these things and I just didn't connect it. So again, it comes back to educational awareness, but also there are a lot of resources out there, but most oftentimes, your teammate, your friend, your child, you'll know when things are not quite right, and then to reach out for care. There are a lot of resources out there, and I think Dr. Lyons will talk about those more in depth, but one resource is our St. Luke's Concussion Clinic webpage. It has multitude of educational pieces on there, as well as our research articles that we've published so far, but even talking people through what do I do when this happens, what signs and symptoms. There's also a video on there for coaches and parents and athletes to watch, just in terms of what is concussion signs and symptoms and management typically look like. So lots of resources out there for anyone interested. So that's what I had to share today. I'm going to stop sharing my screen and let Dr. Lyons take over from here.
All right, are you guys able to see my screen or? All right, are you able to see that there, Soraya? You can see that? Okay, and you can hear me? Okay. All right, sorry about that as I was getting through with this. I'll try to stay in my lane. There are so many different parts to concussion that I want to make sure that as I talk about baseline testing, psychological aspects, and then the resources, that I don't diverge into the other elements that are related to concussion. There's so many interesting tangents that we can go off of. And the other thing is that there are a lot of personal or clinical assumptions that doctors and healthcare providers make about head injuries. And I want to make sure that I try to stay within boundaries of things that are evidence-based. So some of my objectives that I want to talk about are these five, or the first is of personal responsibility. As a physician, I have my responsibility of what I need to do to study, to learn, to recognize signs and symptoms, to understand treatments. But I also believe that it's a patient's responsibility to take complete ownership for whatever's happening to them. And so it's got to be a union between the patient and the doctor to be able to work together to get the best outcome. And the second is to have realistic understanding of the landscape, to understand what we truly are before we ever have a head injury, what our capabilities are, what our physical and psychological status might be, and then what has truly happened to us, how much of this injury is truly going to affect the tissue level and the mind level, and then what we expect to be after things happen to us. I think that in our culture, sometimes that when quote unquote bad things happen to us, we think that it's a negative part of our life. And I just don't believe in that. I believe that everything can teach us something. I believe that Viktor Frankl taught us you can live in Auschwitz and become psychologically incredibly resilient. And so I think there are different things that we can learn from others and learn from what we go through. The third is this learning from others, the excellence in others. I love Christy's presentation. What Christy and Dr. Nilsson have put together here in Boise is absolutely fantastic. This is a great concussion clinic that those two have worked on, and many, many others, but the way that they've put it together is a fantastic resource. The fourth is, what are our behavior patterns? And how do we conduct our life? How do we conduct the plan and the goals that we want to have? How well do we stay focused on them? And I think that's a really important objective of this talk. And then the fifth is the support systems. I loved what Christy said about social isolation. We have to make sure that we develop a team approach, not just with concussion management, but in our lives together. And I want to talk a little bit about the history of that and how that fits in with our evolution. When you think about the history of baseline testing, you can go back 200,000 years from where we are right now, and Homo sapiens starting to gather together in communities and in small groups and being able to communicate with one another to survive, and then to basically dominate, to where about 30,000 years ago, they're the only ones left. And a lot of that had to do with their ability to communicate and work together. Then if you go a little bit further, you see people on slave ships, that the pre kind of exertion baseline testing was, well, as long as the person can row a boat, we'll just throw them in the boat. And then the gladiators, you look at the Roman Empire, and they started to become a little more scientific of which different gladiators would battle the best. And I'm sure there was some degree of pre-participation evaluation with those. Then when you get into our last century, in the 1920s and 1930s, there started to be a lot more research and evaluation of what it meant to have shell shock in military situations, or what it meant to be punch drunk from recreational, from boxers. And then we go forward, we go to the current era that we have now. We have executive physicals where doctors will stick middle-aged executives on treadmills and see how well that they'll tolerate stress to them physically. And it's basically a way that a corporation can tell, is this person physically going to be able to endure some of the expectations that we have as a company? You look at the NFL, the NBA, any of the meat markets of professional sports, and this is basically, is this investment going to pay off for us? And so baseline testing to figure out whether or not these people can survive and actually excel is a huge, huge part of that. My background is with NCAA and doing preseason physicals on thousands of athletes, and being able to see what kind of deficits do they have to begin with, and what kind of things do we need to look at. We're all familiar with high school physicals, but I'd like to talk about the future, that each one of us that is listening today, we need to know what our physiologic and our psychologic baseline is, and be able to try to evaluate where we're going and really what we want to accomplish. Now, when we talk about baseline testing, primarily it deals with cognitive or neurocognitive function, and then with a physical assessment. We go through what a current physical state is, and then what a person's balance or sway is. And those are the typically main points to baseline testing. But I'd also like to talk about psychologic baseline testing. So the neurocognitive testing, I don't want to spend too much time on these. Christy showed that image of the concussion assessment tool that comes from the standard concussion assessment tool that has gone through a number of iterations. You've got, the red flags and things that observe is someone breathing, and at the time of an incident, check what their Glasgow Coma score is, do a cervical spine exam. But for a lot of the neurocognitive testing, baseline testing that we're talking about, we want to know the history of an athlete or of a patient. How many concussions have they had? What's the length of their recovery? But we also want to know their medical history. Do they have migraines? Do they have sinusitis and allergies? And then psychiatric history, any depression, any anxiety, any ADHD or learning difficulties are really important. Now, there are a whole host of graded symptom checklists. And Christy, that cracks me up that you use Dwayne Johnson PECs. I'm going to try to get that out of my mind, but now that's imprinted and whatever that says. So these other elements of neurocognitive testing, orientation, memory, concentration. It's funny doing the memory one. When I worked in the neuro ICU at the University of Utah, I remember being on call for different nights in a row, and I would go in and do neurologic exams. I didn't know what day it was, and I'd ask people what day it was, and then I'd look at them and go, well, they're better shape than I am. They're just barely out of a coma. Processing speed, reaction time, calculation. Abstractions are very interesting. When I see a college student or college athlete that doesn't understand abstractions, I really wonder whether they've regressed. And then neurologic screens, are they able to read? Are they able to follow directions? And then we'll talk a little bit more about visual acuity testing, and then the computerized testing. Back 25 years ago, I worked with a group that was developing a computerized testing system called Impact, and I was collecting data for them at that time. And to watch what Impact has become is very interesting to me, not just from how it's utilized, but the perception of what Impact is telling us. I think it's important for us to recognize its limitations. The physical exam, again, I'm going to jump past these first two bullet points because this is on field, and I've got different stories relating to those. But being able to understand whether a person comes into your clinic with, a frequent migraine, headaches, sinusitis, or if they are acting goofy at the time, could they be dehydrated? Could they have a diabetic issue? Other etiologies are important. As far as the vision screen, we all know the eye chart, Snellen eye chart's pretty easy. The pupil screen is interesting. I had a athlete a number of years ago that she was a softball player, and she had one pupil bigger than the other. And I marked that on her pre-par exam. I'm like, she's got anosacora. And it's just one of those little elements that I remembered. Well, she was a third baseman for our softball team, and during one of the spring games, she took a line drive right off her forehead, and when she hit the ground and people went around her, I heard a number of people kind of hysterically going, oh my gosh, her pupil is bigger than the other. And I don't know why, but I remembered her, and I said, no, it was that way before she got hit in the head. And it's one of those things, being aware of a baseline test is very important. And that example has stuck in my mind because that could be a significant finding. The King-Devick test is a test where you read numbers in a different zigzag pattern, and you can go to letters. And it's not just your vision screening, but it's how your brain is processing the information. The balance error stance scoring is a very interesting 6-element thing where you do different stance and you balance on a foam pad, and the way that you're able to navigate that in your coordination, your proprioception relative to the Earth's center of gravity and your own center of gravity is another way that we're able to test that. Force plates, when people walk across them, are also very informative. Sway testing, which is going to be part of one of the programs I'll talk about in a second. And then the vestibular functions that you can do. You can do VOMs, you can do head impulse. The Dix-Howpike testing are very interesting tests that you can tell when people have prolonged dizziness or excessive kind of dizziness and vertigo after a head injury. Pursuit, saccades, and convergence is basically the motion of our eyes and the way that we process that information. And you can sometimes very obvious, but sometimes very subtle signs of brain injury. It's important to get an idea of where people are with that. I've seen a number of people who have no history kind of head injury, but they don't do very well with some of these pursuit and saccade tests. So having an idea of how they do on a baseline can be very important. The program that I want to talk about is this C3 Logics, which Christy is very familiar with. The Cleveland Clinic put it together, and the St. Luke's Concussion Clinic uses this, and they use what's called performance polygons, where you have these different parameters, the graded symptom checklist, the memory and processing speed, and the reaction time balance. Basically what it does is it draws a polygon for you at a baseline, and then when an athlete or a patient is injured, if you have a follow-up test, you're able to tell where is their deficit. Is it something with their visual acuity? Is it, you know, their neurocognitive or separate parts of it? But this performance polygon gives you a chance to really evaluate and see where they are compared to a baseline. Now, the baseline testing is fascinating to me in that at the University of Oregon, we had real trouble with some of our football players that they would sandbag their baseline testing, that they would intentionally do poorly on their baseline testing so that when they got hit in the head and then we would evaluate them, they seemed like they were doing okay. And you look at some of the scores and you can tell when people are faking and trying to make up things, but sometimes it's not so easy. And I'm sure that there are people that fooled me. Now, I want to talk a little bit about the psychologic baseline testing, which I've never heard of. Nobody does it, but it's one of those things that I think is very important. As a team physician, I tried to do this with the sports that I worked with, is that I think it's important to not only understand the integrity of the brain and how well it calculates and remembers, but I want to know the integrity of the mind. What is this person made of? What are they really wanting to become? And how do they see themselves, and how much have they bought into what they're doing? Understanding their pre-injury baseline state can be kind of difficult. And granted, I didn't have an exact science with this, and I have different things that I've put together, but I've never seen a program that outlines this. As anyone who's worked with athletes or patients, you realize there are preconceived beliefs people have. I would see rodeo athletes, football players, hockey players, gymnasts that had preconceived beliefs about what head injuries were, and they would land on their head, they would get up, they would perform, and physiologically they might be intact or they might be a little off, but they acted very different to other athletes. We had one of our track kids at Oregon that he was running for a recovery run across the Stanford campus one night. And as he's running across, this kid on a skateboard goes flying across the flower bed and hits him in the head with a skateboard. Now, the track athlete, that's not part of his sport. He certainly didn't expect that when he went for a recovery run. And I'm not totally sure whether the psychologic damage wasn't greater than the physiologic damage. The hallmark of concussion is that we don't have great physiologic markers that we can follow. We don't have scanning techniques. We can PET scan people. We can measure tau proteins. We can measure different metabolic variables, but we don't have a lot. So I think it's important that when we're doing baseline testing, whether it's physiologic or psychologic, you want to know what's their previous neurologic damage. Do they have any axonal shearing, shaken baby kind of stuff? And you know, some of us who go to amusement rides, we're gonna shake this little, you know, piece of jello inside of our brain, inside of our skull, and it's going to maybe cause some damage. Previous concussions, any environmental or psychological insults. And then how do we measure those? How do we measure how much history of substance abuse messes people up? Now, another area, and I specifically wrote it this way, what's the underlying pre-injury ventromedial prefrontal cortex regulation of the amygdala interface? The connection between our cortex and our midbrain, between our reason and between our emotional state, we all have a certain stability to that. Just like my vision or my vertical leap or anything else, we have a certain stability. Then and when that is disrupted from a concussion, how is that changed? And there are certain things that we can do that we can improve our impulse control. But when you think of that, when you think of all the neuromatrix variables, the genomic upregulation of hormones, receptors, that is why if you've seen one concussion, you've seen one. None of us are the same. No two concussions will ever be the same. And therefore, no two treatments should ever be the same. That doesn't make sense to me. So there are certain standards and certain things that we can follow, but we've got to individualize things. There's also, when you think about someone's premorbid anxiety or what their anxiety sensitivity is, that's very important to keep in mind. A person's cognitive bias, or something called misattribution, which is basically how much value we assign to our expectations. And when something happens to us, we think, oh, this is going to be terrible, or this is going to be fantastic. A person can live in poverty and become a king, and they attribute it to their poverty life, or a person can remain in poverty. And neither one of them are completely wrong, but neither one of them are completely right. So we think of that. We think of what's the at risk for neurobiological depression and or anxiety. And it all comes together as basically, what is your psychological resilience? And I find it very interesting when I've worked with a lot of the athletes of getting an idea of how resilient they are psychologically, not just physically. So some of these psychological aspects is, where is that crossover between the physiogenesis and the psychogenesis of the damage that happens? And it's fascinating to me that working with and studying concussion since the mid 1990s, I have seen how this has gradually evolved. And with some of the education, there are a lot more things psychologically we're dealing with now that we never used to deal with. So I have this example of Eric. He was a wide receiver that my first day on the job at one of the universities that I worked with, kid goes across the middle. He gets just laid out by a defensive back. Nobody knew the kid's name. He didn't have any kind of name on the back of his helmet. I'm asking the coaches, I don't know the landscape here. I'm like, well, doesn't anybody know him? Who does he live with? Nobody knew who he lived with. So I basically took him to the hospital and admitted him under John Doe so I could watch him for the night. And later that night, I found out his name. I found out he lived by himself. And then I found out that he wasn't from anywhere near the university. He lived thousands of miles away. I followed up with him over the years, and 6 months later, his mom said, my son, who she brought back home just a few weeks after the concussion, she said, my son never returned. 2 years later, when I talked to her, she's like, my son's still not the same. And I've wondered with this kid, how much of it was physiologic, how much of it was psychologic. And I really wish I could have worked with him for longer than just a few days to see what we could have done to try to help him. So it's pretty common that when people are concussed, and I think this is a fascinating thing, if you look at concussion studies with people who are in work compensation environments, that the underestimation of some of their pre-injury problems and the overestimation of their pre-injury health and post-injury dysfunction, it's fascinating. And you ask a rodeo guy or a football guy, and it's different than some other people. They're like, no, I never had headaches. Now, some of it is the storytelling. And I'll go back to 200,000 years ago with Homo sapiens, when they developed communicating abilities and they could tell stories. We're not the only species that lie to one another. Green monkeys and chimpanzees, they lie to their other chimpanzees and monkeys to steal bananas from them. And we create stories at times for different reasons. Now, those misattributions, the misconceptions, and different pressures, and I thought Christy did a fantastic job talking about those that come from coaches and teammates and different things. So when the injury occurs, you get this injury cascade, limited blood flow, metabolic energy is limited, the CSF circulation becomes restricted. You get multidimensional functional pathways that become disrupted, and you develop some homeostasis failure. But a concussion's invisible. Athletes feel this loss of participation, sometimes inclusion with their team. And Christy talked about that. That social isolation is huge. This is where it's different than other injuries, because it's not just the body that's injured. And I'm not saying that ACL tears don't have a psychological element to them, but they usually don't have that combination of my brain is damaged along with my mind, and my future is now dramatically compromised. So there's that guilt, the anxiety, loneliness, and what I've coined the phrase, I know it's grammatically incorrect, of a shaken identity. And again, Homo sapiens tell stories. If you want to learn more about that stuff, Dan are really a Duke researchers. That's fantastic information. So we could talk about some of these other parts of concussion psychologically, of where PTSD, relationship problems come in. But basically it boils down to, are people going to go alone or in a team approach? And communication in a support group, whether it's friends, family, coaches, teammates, but medical providers, working with people as a collaborative effort is the best way to do it. From my 2 cents worth as a sports medicine doctor, I think we've got to change our paradigm. We should look at injuries and pain as something that can teach us. We can learn from them. We shouldn't be worried about the timelines. For 20 years, I've had a graduated exercise in what I call the 5 sense stimulation program, where I try to get people to think about how they sleep, how they eat, how they manage stress, how they return to learning, and how they return to their activity. And basically, it's how do you get to return back to life? And these different areas of psychological rehab with imagery and CBT and those different things. Now, Christy talked about some of the different resources in the community, and I won't spend too much time on those. At the University Health Center, I evaluate different patients. The counseling center's right down the hallway. The EAC is a tremendous resource, and then community resources that are very, very useful. And I didn't want to take too much of what Christy does with the concussion clinic, but they've got different connections with cognitive vestibular rehab, PT, OT, the speech language pathology component that she knows so well, and then what is called the outpatient brain injury program. I've listed here some online resources, the CDC website, the Duke Sports Concussion program put together a really short, quick YouTube group of videos. I think is fantastic for baseline testing. Children's Hospital of Denver, my old boss, Dr. Cantu at the Emerson Hospital Concussion Clinic, Boston University, and then those guys that did Impact at Pittsburgh. So basically from baseline to psychological aspects and resources, understand your now, be aware of what you are right now, what's happening to you and where you want to be aware of your present moment. Seek evaluation from a team approach, get a specific plan from the doctor for sleep, stress, pain, activity, education, and for heaven's sakes, get back to life, get back to life, get back to life. And this is one of the things that I go through with patients all the time when I'm trying to work with them. So the take-home points are the responsibility, understanding reality, seek excellence wherever it is, think about our behaviors, and then the support that all of us can use. Thanks.
Thank you so much, Dr. Lyons. That was great. We do have a couple questions in the chat that came up. The first one asks, how do you think healthcare professionals can help to address those misconceptions and help people to more accurately understand their pre-injury condition or baseline and the impacts of their injury to avoid that under and overestimation?
I think for me personally, when I see patients, it's very difficult in a 15-minute visit to develop trust and communication with them. And so what I try to rely on is tying them back into people who do know them and that they can trust. And so I talk to them. One of the parameters I use with my patients is I tell them of my 5 senses stimulation program. I say, I want you to contact the people who are most important in your life, your support staff. Talk to them about why they're important to you. I don't want you to talk about your concussion necessarily, because I don't want you to give it value in a negative way. And so to educate them to realize, okay, you have an injury that's occurred, but there's a part to it that's physical, which 99% of the time they recover from. And let's say they don't. Let's say that your brain is scrambled. What the hell are you going to do with that now? You may not be able to change it. This is reality. What do you do with it? And it's usually not on the first visit that I'm going into that much elaboration with it. But I do tell them, I'm like, this is where you are. You've got a lot of support. You've got a lot of resources. I want you to talk to the people who know you, who trust you. You trust them, you love them. And that's what I try to do. And I hope that educating them in a way, in a team approach is the best way that I can think of.
That's great. We have somewhat of a follow question asking about how does a faculty member help, but you kind of mentioned that, just building trust, but how would you suggest that in a team-based setting for those who are working directly just with athletes on a everyday, say in a football or volleyball setting?
I don't know any other way of saying it, but if you're a team doctor or if you're a teacher, you have to be invested in the people that you're with. And I feel like at the universities where I worked, I knew the athletes and I knew where they were from and I cared about them. And as a teacher with my classes, I tried to do the same thing. Is that I think that's how the team approach becomes stronger. With certain people that I don't have that, I don't want to fake it and try to pretend that I know them better than I do. But just let them know that I'm available to them. And I'd hope that teachers are the same way, that I've never understood, and we all have been in this spot, professors or teachers simply want to show how smart they are versus trying to help us learn and help us become better educated. And I've always hoped that that's part of my role is when I was teaching, was that, yeah, I can help them learn and be a resource. If I'm closer to them, then I hope I'm a stronger resource.
Thank you. There's one more question. It's about noticing there's a 14-day return to play program with high school level rugby and football and other sports that's based around symptoms and getting them close enough to their baseline. In your experience, and this can be either towards Dr. Lyons or Christy, is a 14-day protocol have better outcomes with return to learn or play?
You want me to start, Christy, or do you want to?
Why don't you go either? I don't care either way.
I look at it this way. The 14-day is a great starting point. If you look at a lot of metabolic studies, the amount of time where there's a deficit can be way, way past 14 days. I think that it's a healthy place to start to say, if you've had from a medical professional evaluating you a significant event where you need to be restricted, then I think it's a good idea that there's a time frame that we hold them out, and that if they're doing better, that we put them through a battery of tests. But I think these time frames, and again, I'm speaking from a background historically where it used to be if you got knocked down in a football game and you walked into the defensive huddle and you're on offense, they just kind of pointed you the other way. And that's kind of how things used to be. And I think that things are much, much better now. I like the idea that we're coming up with timelines, but I also fear that we try to plug everybody in the same one, right. And that makes me a little bit.
And yeah, just to kind of add on to that, what Dr. Lyons is saying, that 14 days, so Rugby Idaho is a group that we work really closely with to support them with their concussion management protocol and education. And that 14-day time frame actually came from the International Rugby Association in trying to develop an overarching concussion management protocol that served anyone around the world playing rugby. The challenge, though, became you have some communities that have a lot of medical support, and then you have some places in our world that are so remote that don't. And so their thought behind it was, as we make it 14 days, then potentially we get out far enough to keep somebody safe. But I think to Dr. Lyons' point, the reality is everybody's different. And so trying to put a time frame on it like that, it was what the International Rugby Association did, to try to come up with a standard plan. But sometimes the concern with it is if an athlete knows that automatically they're out 14 days, they may not report. we have seen that here, which is why we really try to work with Rugby Idaho and provide education for coaches, athletes, parents, and officials, and make sure they have a good protocol. Because sometimes it may take that long and other times it may not. And so it oftentimes is more fluid than that. Typically it's minimum 7 days that somebody's going to be out. If they're able to, we're looking at getting them back to school and then going through a stepwise return to sport strategy. But that's where that 14 days came from in relation to rugby.
Great information.
Mm-hmm.
And then there's one more in the chat that came through that I think we have time for. She comes from a community that has recently been exposed to the dangers of ignoring concussions and CTE, and is wondering if this is an area that should be more commonly stressed in sports, would be to monitor for longer lasting symptoms beyond just reaching the original baseline testing again.
CTE is a pretty complicated topic. We talk about different factors. Basically, some of the measures right now that they have for CTE, I don't know that they completely correlate with the injuries that people had or that they're having, and how does beta amyloid exactly contribute to dementia and or Alzheimer's disease. I think it's important that we keep our ears to the ground. We continue to research this. There is a certain degree of hypocrisy in humans. I ride my motorcycle without my helmet at times. If I could play football today, I would play. But it's ridiculous to think that I can walk into a football field, run full speed into another human being, and think that it's healthy for my brain. That's foolish. So I think that we have to understand and accept reality. There's certain parts to this that we're going to try to protect people as best we can. But life on this little dirt clod, we're going to have issues. And that I think that we have to accept that, and that when somebody has issues, to open up all kinds of litigation and different things. The pendulum has swung, like everything, it swings a little far. But I think that it's important research that we try to filter out what is CTE, what things are we doing in our life. But if I struggle with just going to bed on time and eating the right diet, I think there are plenty of health things I could do better, short of bouncing my head off of somebody else.
Definitely. Christy, did you have anything to add? Any final thoughts?
No, not on that one. Thank you, though.
All right. Well, we have reached our time limit. Thank you, everyone, for being here. We really appreciate it. And thank you, Christy and Dr. Lyons, for sharing your experiences and, like Tara says, your expertise. It's really greatly appreciated from me and all of BroncoFit.
Thank you.
There we go.